So I'll leave more time for other questions, but just asking what happened to the control group, just so you know, after the experiment, we gave them feedback. We gave all participants that wanted it feedback, and they reported that they actually didn't know which condition they were in. They didn't know they were in a control condition. Some of them actually enjoyed the multiple questions about their lives, and others found it restricting, especially restricting their answers.
Reducing affect or negative affect in order to get as good as possible homeostasis in the whole system. Now, another thing is that, as I said, there are different ways of reducing free energy. The two main ways are changing the model or the prediction, according to the perceived, and the other way is by acting, by doing something, something with our agency, right, on the world, to act upon objects in the world in order to change it and make it fit our models or the way we want it to be. And this is very important because, our bodies were not planned to sit on couches or to only lie down on couches in psychoanalysis, but the fact that we can act upon the world is very important as an intervention, as a possibility for regulating ourselves and reducing our free energy and our prediction errors. And actually, in our forum here, we have all kinds of therapists. We have movement therapists and dance therapists, and there's also today the touch, right, Oliver, the affective touch. Katerina Fotopoulou is developing this very nicely. So this is another channel through which things can be changed, not by us as psychologists, but there's a lot of power to different kinds of levels in which we can reduce free energy, okay, and not just this this intellectual cerebral talk. And about the neurological patients, I can say that what we're doing with these patients is actually we're there for them along or through a process, especially in the first months after the lesion, after the stroke, like Emma, the patient I talked about it's a period that is called dynamic period because the brain is organizing itself, okay, and things can change spontaneously. There's what is called the spontaneous recovery in this time. And what we're doing, what we're trying to do not just in psychotherapeutic rehabilitation, but in all rehabilitation, also in physiotherapy and occupational therapy and speech therapy, is like supporting this process of a spontaneous recovery. Okay, and we're trying to to lead, okay, you can say, the neuronal networks or neuronal pathways of recovery to the right places in order to get as much function, okay, and independent as possible. So when we treat someone like Emma, you start treating her, you don't know how far it will go. You see, sometimes we see amazing dramatic developments or recoveries from something which looks like dementia to almost full independent functioning. Okay, this is unfortunately not most cases, but things get better. And what we're trying to do is to support these processes.
Can I try a little bit more, number two? Sorry, I will try to be brief. So it's the question about how is it possible for these people to recover when the brain has become damaged? I mean, the two things that I would say. The first of them is that these patients they're people like you and I in this room, they come to it without any of the environmental challenges that many psychiatric patients have had earlier in their lives, and without many of the genetic disadvantages that they may well have had during their lives. They're as normal as you and me. Secondly, they also lose only a small part, if they're stroke patients, of their brain. They lose one cognitive system, but there are many other opportunities for recovery in patients of this kind, and yet they don't receive psychotherapy. I don't know what it's like in Israel. If you're a psychiatric patient with a mental health problem, you have a reasonable chance of getting treated in Britain with psychotherapy. If you're a neurological patient with a mental health problem, your chances are much smaller, unfortunately. So I think it's Yeah, unfortunately. Oh, you mean here? Yeah, no, whenever I've talked in the world.
But they do get psychotherapy here, also the neurological patients in hospitals and rehabilitation hospitals.
Yes, but still it is not really integrated, not like our understanding that where your psychoanalysis is ending. They do not get this understanding that they're not that different. That we can think of it in a more integrated way, not psychiatric and normal. This is
Professor Turnbull, you haven't answered the question, though. I understand that. I understand that fully. There can be so many other parts that would kick in and help. But if you're talking about losing something about object relating in the world, a special part of your right-hand side, or some capacities, then it's curious how we develop that, despite if that's essential, then how are we developing? And do you understand?
Firstly, I think the functional systems concept, which we're very big on in neuropsychology, is about finding different routes to achieve the same goal. And the brain has more than one system. For example, I care about emotion regulation. I could name at least 3 cortical emotion regulation systems that are differently located. I think in the acute stages, you see the system collapse, but it does, as Kobi said, recover, and they can make substantial progress. I'm not claiming miracles in our patients. I just think they deserve an equal chance with the psychiatric patients. Mm-hmm. Did you want to go at number 3?
No, you go.
This was your lethargy after your father's death. The one thing we do know, sorry to return to the question of agency, about depression and its chronic circumstances, is that it's not just that feeling of psychic pain, which we know is mediated by the opiates and the panic and so-called grief system in cancer. We're well aware of that, and because the kappa opioids, no new opioids that are involved in the process. It also seems that the seeking system drops dramatically in its function during those stages. And indeed, as Joram Revel's work points out so clearly, the real risk in patients who are depressed and then get antidepressant medications that improve their mood is suicidality. So they start to get enough energy to be able to kill themselves in a way that they hadn't previously. So it's not my place to make a comment there, but I think the lethargy of depression is undersold as relative to the psychic pain element of it.
So what would it be about talking that helps work that through in terms of your neurosciences?
So if I was going to have had a go at your first question, I was going to say something about a terribly crude generalization for which I apologize. But it seems to me as if the pharmacological interventions are dialing up or down the basic emotion systems. They're about subcortical systems and having more or less of something. And they on their own have all sorts of flaws, which I won't repeat here. The talking cures seem to have much more to do with cortical systems and emotion regulation, and using cognition to harness those emotion systems. I'll give you my best example from one of our papers. We've studied patients with it's not on anymore. We've studied patients with left frontal lesions who struggle with reappraisal, which of course is a core therapeutic skill, and we now know the sort of lesion site and what it looks like to not be able to reappraise. We are then able, in a group study, to identify which psychological processes underpin reappraisal, and there are 2 of them. The first predictor is inhibition, and the second is verbal fluency. So it looks like reappraisal works. In inhibition and verbal fluency.
What did you mean by reappraisal, though? What did you mean?
Looking, taking a bad, the classic experimental task is a car crash with the firefighters are all over the car, tearing open something which has been a bad accident, and the experimental task is, tell me something good about this. Because that's what depressed people can't do. They just can't see that anything, they can't reappraise a negative situation in a positive light. As some of our left frontal patients can no longer do that after a brain lesion, although they were normal 6 months earlier. And the 2 psychological processes that underpin it are inhibition and verbal fluency. So we think that reappraisal works. Firstly, I look at a picture of a car crash and I go, oh my God, that's very sad. but I can, if I have inhibition, I can control that. I can contain the sadness. And when the sadness is contained, I can then use my linguistic powers to say, well, obviously it's bad that there's a car crash, but it's good news that the emergency services have arrived. Or maybe they had airbags in the car, so they'll be okay, even though the outside body is injured, you know? That those are the reformulations. And our patients lose that ability, which means they keep being depressed. We have a lovely patient in one of our other papers. He's an ex-academic, so he produces better, more florid language than we can manage. He calls it a sticky sadness. He says he gets sad and he can't stop himself from being sad. But we know, as every neuropsychologist and neurologist in the world knows, that frontal patients, although they can't manage executive function on their own, external sources can modify the situation. And what he describes is how his wife helps. He says, when I'm in the sticky sadness, I can't get myself out of it. But my wife, she helps me to see a more positive way. So she does the job of saying, I know you're sad, but look on the bright side. You saw nice flowers in the garden. You know, maybe tomorrow will be a better day. Whatever it is that constitutes a reappraisal. So I think it's that way that we're trying to understand a little better. I don't know if that's an answer, but that's my best at it.
We have actually another question for you regarding therapeutic implications.
Regarding your last talk about midbrain, I'm thinking about my patient with midbrain injury and suffering struggle to understand what he's feeling at the present moment. Sometimes he can, 1 month after somebody maybe said something bad to him, get reminded that he's angry about it. So I would continue your line of thinking. How would you treat it in psychotherapy?
I've honestly never treated a patient with a focal midbrain lesion because almost all of them are not conscious. You know, was he in coma beforehand and he's now in some in-between state of partial consciousness? Really?
But maybe some kind of medical miracle, I don't know, but now
he's working, did you say? And which other symptoms does he have apart from this strange alexithymia that you described?
He's not aroused, he's very tired. Often he had attention problems, executive functions problems, even though he was injured only in midbrain and thalamus.
Yeah, but firstly, there's a very interesting patient. You need to send that. You need to write him up. I mean, the reason for.
Does he speak? Does he speak? Does he speak? Does he have any reaction? Does he speak?
Yes, he speaks. He's very wise. He's very intelligent.
What is the chronicle now? We have a patient at the moment with actually working.
Well, firstly, I don't know about his neurologist, and we've got several neurologists in the room here. Maybe someone has some suggestions about whether there are some pharmacological interventions. Yep. Sure.
Now, we had that patient that just woke up. Would you like to say something?
I don't. Pharmacology.
For his poor arousal, I suspect that there's some reticular formation problem of projection forward to frontal cortex and all sorts of other arousing systems that may be at fault here. But behaviorally, this is not a very psychodynamic interpretation, but if he's tired, I wonder whether there isn't some planning of his life that would be a little bit better. A lot of our patients, not with brainstem lesions, but with traumatic brain injury, we run a rehab program, and we recommend that they pace themselves better. What they tend to do is do something for a little while, push themselves too hard, and then they can't work for 3 days. It's better if they just put in solid blocks of time, and often because they're dysexecutive, they're not very good at stopping themselves from over-tiring, and therefore we often use smartphones with reminders so that you say, I will just work for 1 hour and then I will take a break, and my phone goes beep, beep, beep. I realize that's not a very psychodynamic approach. It's a very...
Some sort of experimentation, but I'm interested in really psychodynamic intervention because he's feeling not the same way he used to be.
That's all our patients. Yeah.
No, but it seems, I mean, among our patients, we had a patient who, as he woke up, when we would ask him where he is, he said he's at home while he was at the hospital. And when we used to talk to each one of us and say, you'll never die, you will never die, you will never die. And what we thought was that he is post-traumatic really, and he should be treated as a post-traumatic. And what we found out is that when you treat him with EMDR, it really helps. So this kind of, not too much of a negotiation, but still being there, experiential feeling like Oliver was mentioning before, like having the feeling that you're with them, as if it goes down there somewhere to these implicit places, you know, and he has like a belief that he'll be alive again. I think it might help. So this is the most of the psychoanalytic, psychodynamic way of thinking about these patients.
We have 2 minutes more. We have here
The question is so long it will take 2 minutes to read.
Yeah.
Shall I summarize what I think it is?
Someone recognize the question? Or?
It's a question.
About familiarity and episodic memory.
Yeah, I mean, you were talking a lot about familiarity during the lecture in the first lecture. And I think familiarity contains also a non-emotional component. So I was wondering how you associate that.
Yeah. I agree that familiarity may contain non-emotional components. And in fact, there's a literature in the memory, in the memory field about the so-called gist memory, which is about the overall narrative of a story. In fact, we've been trying to push the idea that maybe gist memory is emotional memory. That is, we partially reconstruct a story by virtue of, the emotional feeling that underpins it. But in that study, there was a graph that I didn't show you, which is which things predict the quality of recollections, and it's not how much our patients have emotion, but it's the capacity of executive function in the patients that best predicts overall memory recall. And it reminds me of something that Frederick Bartlett said in the 1930s about memory. He wrote a famous book which he refused to call memory and instead called it remembering, because he said that memory is always an active process, a process of reconstruction, and it looks as if our patients who are dysexecutive aren't able to build the Lego bricks together of a solid narrative. And I think a part of that is emotion, but another part needs more complex executive function. Sorry, do I think? I think the more you can energize that system for good reasons, so long as you're not manic, then it's very good for almost all mental activity. Jacques talks about it being the first and the most important of them all. So, and by the way, it gradually declines a little with age. So, anyway.
Unlike our Israeli way, we are just in time. So to thank everyone, first to thank.
Can I thank you very much? It's been absolutely wonderful being here.